Thanks for a fabulous talk. It deals with the patients that I certainly deal with, and I know that a lot of people here are dealing with on a daily basis. And it means that we really need to focus our attention now again on these individuals with long-term mental health problems. And so it's very important. It's very topical at the moment. There's a lot of discussion about services in Australia and across different states. And I'll ask you one question which I'm interested in because of the issue of how long some patients stay in the unit that I work in, and speaks to the issue of, well, are there new long stay type individuals that require hospital beds? And if so, how many beds does one need?
It's a sort of impossible to answer question. I mean, the short answer is yes, there are. How many beds? Well, that depends what else you've got in the system. But you will need some beds, and the length of stay in those beds also depends on what you've got going in that unit and what you've got in the community. So it has to be worked out locally with everybody thinking about their resources together.
Questions?
Hi, Helen. Thank you very much. My name's Nicola Hancock. I'm Associate Professor and an Occupational Therapist at Sydney Uni. You mentioned, I think, PCLI, Pathways to Community Living here in New South Wales, and one of the things that we see is the real challenge in shifting practitioners to being recovery oriented, and you keep mentioning it, and I think it's so my question is, what's the trick that you've worked out in the UK? Because we certainly struggle here to shift, particularly people that have worked for a long time in institutional context when they're moving to community.
Well, first of all, it's challenging people to be more recovery oriented in a kind way. People don't mean to be institutionalising, but they're often coming from a rather sort of maternalistic or paternalistic place. Very rarely you'll get someone who's really dodgy and you just need to get rid of them. But, generally staff are not like that. Generally they're there for the right reasons, but they haven't necessarily fully understood that what they're doing could hold someone back rather than supporting them. So I think going through all of your systems, everything you have in terms of the way that staff interact with service users, the way that you review service users' progress, the way that you involve service users in care planning, the way you involve service users in running the service, thinking about how you're going to do that in a more recovery-oriented way, and supervising staff individually and at the group level to challenge themselves and challenge each other, to think, is there a way I could do this in a more collaborative and individualised and hopeful way? And evaluating that using things like the quirk that I mentioned is quite helpful, because nobody wants to be scoring below average on anything. That's sort of human nature. So it's useful to say, gosh, we're really low on this particular marker. What can we do to improve it? And that particular measure gives you prompts as to how you can improve your service too. But it's not that we've got it sorted in the UK. There are plenty of places where recovery orientation is not where it should be.
Chris.
There and then.
Hello, Helen. I'm Partha Das. I work in a rehab, a community care unit in Victoria, which is a long stay unit in the community. And looking at your slides as to who is suitable for rehabilitation, and the first point is complex patients. Mm-hmm. And what I, in my brief experience as a rehab psychiatrist, I found that sometimes we wait for the patient to become complex. And sometimes it is complex because the system is so fractured and it has no fault of the patient. And the problem in the system is that the gap between a community service and a rehab service. So in parts of Victoria, we have lost what we call the mobile support team, which used to be the assertive outreach teams. And the gap has become bigger, and there is nothing to replace that. Do you have any comments on that?
Well, I think that's what I was getting at, and that the NICE guideline is trying to get at as well, is that if you talk to a lot of psychiatrists working in early intervention services, they can spot people quite early on who are not doing well. It'd be a small proportion of people coming through, but they will be able to pick up these are people who are not responding well to treatment. And we should be identifying that group much, much sooner and getting them across to rehabilitation services to prevent further decline wherever we can. In terms of, how you shore up your community services to provide the ongoing rehabilitation when people leave those inpatient settings, that's a thorny issue. That's why we have community rehab teams. Community rehab teams disappeared almost completely in England in about 1999-2000 because they were all rebadged as assertive community treatment. I then did a trial that showed that assertive community treatment had the same outcomes as standard generic CMHT care, and all the ACTs got closed. So that was a bit embarrassing. And actually the quality and not quality of care, but the resources for CMHTs have dropped in the last 15 years. And so now people are realising that the role that ACTs had that was previously held by community rehab teams needs to come back. And so there is now some will to reinvest in those. So I'm not sure of the political status in Victoria, but it's making that case again that you need them to continue that work.
Thank you, Helen, for your presentation. In Australia, we're having our own discussion, I suppose, about a whole of system approach. That's through the Productivity Commission review of mental health services in Australia. And they describe the mental health system as basically dysfunctional. But when it comes to the community-based psychosocial system, they say that there just isn't a system. So I suppose this is my question is really the balance to Christos's question about how many beds. Well, how many psychosocial support services? How do we get that message through in terms of how we are developing a better whole of system approach to mental health? And what we often hear is that there is no evidence to, and I think somebody else made the observation earlier that we don't have a language often to describe, let's say, a recovery approach or a psychosocial support approach. We don't appear to be able to demonstrate to decision makers that we even have the evidence to support that, or the cost-benefit analysis. But obviously you have been able to do some of that. How successful were you in providing that evidence to the discussion around a system-based reform around mental health in the UK, and the cost-benefit analysis, and how much of that do you think is translatable to Australia?
Well, I don't think that we've got evidence that says you need this many people to live this type of psychosocial. It's certainly not at that granular level. One of the things that perhaps the UK has an advantage, or England at least has an advantage in, is that because there is this sort of local responsibility for commissioning the right services for your population, if you can get into that conversation, and that's not easy, but if you can get a place at the table for that conversation, you can influence the people who are planning services to think about the needs of this group. And then again, it comes down to nice guidelines, saying that we need people who have these diagnoses need these sorts of treatments. So you can wave that around a bit as well. But as Till knows, not everything that should be in there is in there, and so you have to make a case beyond that sometimes as well. So I would argue really use the documents that exist, but also think about how you make the case for what you need at a local level, however big that locality is.
Helen, I'm Luis Salvador from ANU. I have one comment and one question. The comment is that we are always talking about the cost effectiveness and if our service provision is expensive or not. And I think we have to recognize that treating properly these highly complex patients is costly.
Yeah.
And I remember I started to work on health economics in the 1980s, and there were the oncologists, ourselves, people working on diabetes, and the oncologists very quickly move away from cost effectiveness analysis of service interventions because they were extremely costly. And they have been extremely successful in keeping their funding. And I think that we should really start by recognizing that we are asking for more funding for our interventions, because our comparators, treatment as usual, it's not good.
Yeah.
The second thing is, what do we do with complex cases that do not have psychosis? I've been an advisor for the government of Catalonia in northern Spain, and the parliament made a request to the Department of Health to focus on this group of patients. They have found a group of patients with behavioral problems in childhood and adolescence with a number of different diagnoses, no psychosis. They are between 25, 45 years old with huge problems, and they are trying to focus on this population group as well.
Well, they need their own nice guideline, in my view. I mean, in reality, a lot of longer term facilities will have people who've got a lot of complex comorbidities. Often the psychosis, although named as the primary, kind of isn't. So I think we see a lot of people who don't quite fit the primary psychosis mold anyway. But it is a problem. I mean, particularly people who have very severe emotionally unstable personality disorder. We're seeing a lot of people in that group in private sector settings not necessarily getting good care. On the other hand, there are some private sector settings that are doing a much better job with specialist groups than NHS facilities ever did. So I think we need to think about specialism for people's particular needs.
I think we've run out of time, but there is a panel discussion, so you reserve your questions for a bit later. Please join me in thanking Helen.